Welcome to Adapting Class, to our Wednesday NCLEX practice question. This is nursing fundamentals case study. We're going to talk about case study regarding fluid and electrolytes. Let's get to the case. This is the case. I give you a scenario and you got to walk through it. This is a 68 years old male admitted with what? Fatigue, dizziness, and shortness of breath. There's a reason why those are the common information. The first thing I give you, pay attention to those chief complaints because it's going to help you answer the question. The chief complaint is what you've been given. Always when they give you a case study, try to take care of those chief complaints and use it as a means of trying to figure out what is wrong with the patient. What is the issue? This patient, this is the history, hypertension, right? Diabetes, recent pneumonia. Those are very important. Pay attention. Look at the vitals. Blood pressure 88/54. That's something should tell you this patient is not doing well. Heart rate of what? 112. Combined hypotension and tachycardia is a bad combination. Respiratory rate of 24. And his saturation is 91%. Something should be ringing in your ear. As you read through the case study, you should have an idea. Hypotensive, tachycardia, shortness of breath, dizzy, fatigue, and saturation is going down. This is the lab. Sodium 128. This is hyponatremia. Potassium is going up. BU and creatinine, they are abnormal. I'm giving you the facts so that you can understand what is going on with the patient. In the last 8 hours, what is happening to the patient? In the last 8 hours, IV fluid that was given about 800 ml. But how much came out? 100 ml for 8 hours, right? That's not good. Patient have IV access, he has 20 gauge, and it's working. So you have 68 years old patient. Think about it. Who was admitted for fatigue, dizziness, and shortness of breath. As irrelevant past medical history as indicated below. A patient is hypotensive, tachycardia, respiratory rate up, saturation going down, and the lab work is not encouraging. You have what? Slightly hyperkalemia getting closer to 6, and then you have sodium of 128. BU and creatinine is going up. What do you think is going on? Something should tell you there's so many things that is not good for the patient. Shortness of breath, I don't like it. Dizziness, I don't like it. So you have to have it. You said, okay, I'm worried. Why would I be hypotensive? Something is not right. And tachycardia. These two combinations, hypotensive tachycardia, should tell you something, right? And then your sodium is low. Is it diluted or you are fluid overloaded? I don't know. Your creatinine is high and your BUN is also high. Are you in renal failure? I don't know. But it looks like you're not making a lot of urine. 100 over 8 hours. Even though your IV is fine. And we've given you 800 ml of fluid. What do you think is going on with the patient? And these are the chief complaints. Shortness of breath, dizziness, and fatigue. So that's what you have. Based on that information, what do you think? You have reviewed the clinical data that is provided to you. Will you assess the client lung for crackles? Which one will you prioritize? Those are the information. Will you prepare to give patient potassium? The potassium is what? 5.8. Will you hold all the antihypertensive medication? She has a history of hypertension and her blood pressure is 88, systolic. Do you start IV bolus right away, 0.9% normal saline? Remember. And do you monitor the client and put the client on cardiac monitor? Think about the situation. The patient is tachycardic, hypotensive, potassium is high, sodium is low, and you have crackles and shortness of breath in the lung, and you want to bolus, you already get 800 ml for the last 8 hours, and only P 100. Which of these should you prioritize? It's select apply. Think about it. Something should tell you, as somebody who has shortness of breath, patient already received about 800 ml of fluid. And how much urine came back? 100. That tells you you should listen to the patient heart, make sure they are not fluid overloaded. That is the key. The next thing you should do, what do you think? Giving a patient potassium, which potassium is already high, you should not do that. You should hold all antihypertensive, right? That is acceptable. This is what the nurse should prioritize. Will you give this patient fluid? Already had 800, and the patient is having shortness of breath. Even though it's hypertensive, you have to make sure you verify this patient is not fluid overloaded. These are critical thinking when it comes to IV fluid, because it's an older patient. If you're slamming with fluid, you push them to the edge. The SAT is 91. You should not do that. And of course, because of the potassium, we need to put this patient on a cardiac monitor. This is the first thing the nurse should do. Now, I'm going to take you some places that you have to apply your knowledge. Order the following nurse intervention. So which one will you do first now? This is the vitals again. Blood pressure 88/54, heart rate 112. And this is the lab again, sodium 128. And these are potassium chloride norms. Do you assess peripheral IV first? Do you monitor the client for EKG changes? Do you monitor urine output hourly? And do you notify the healthcare provider about the potassium? If you have to order this step, which one would you do first? Is prioritization. Patient has just shortness of breath. Patient is hypotensive. You have hyperkalemia. And if you have to do this, what would you do? Of course, I got to talk to the doctor first. And then we got to monitor the EKG changes so that we got to make sure potassium is not affecting the heart. And what are we going to do? Monitor the urine output. We give the patient 800 ml and only P 100 the past 8 hours, right? Then we can assess the IV, make sure the IV is working. Now, what do you think? This is the key now. Now, you have to provide fluid. Those calculations can be very intimidating, but this is not that difficult. You can master it. If you have issue with it, I will show you. The provider order maintenance IV fluid. The patient weigh what? 70 kilos. What do you think? Calculate maintenance fluid per 24 hours. Those calculations, I think sometimes you have to know it, but don't worry if you have issues with it. This is straightforward, right? The patient weight, all you need to do, take the weight of the patient. Patient weighs 70 kilos. How would I know how much fluid they need over 24 hours? There is a simple method. Take their weight, first 10 kilos, right? And multiply by 100 ml per kilo. This will give you what? 1,000. So 1,000 ml. Take the next 10 kilo of their weight and multiply by 50 ml per kilo. And this will give you what? 500. So that's the way we're doing it, 500 ml. What is left? Patient weigh 70 kilos. And we've used what? 20 kilos. So what is left? 50 kilos. Now with the 50 kilos that is left, you just multiply by 20 ml per kilo. This is the 24-hour rate. If it to be an hour rate, you just use 4 to 1. You put 4 here, you put 2 here, and you put 1. But because this is 24 hours, we got to use 100 ml, 50 ml, and then 20 ml. And these also will give you 1,000 ml. So that's what we have. A total of this will be 2,500 ml. This is how much fluid the patient needs within 24 hours. So 2.5 liters of fluid within 24 hours. This is how we can resuscitate the patient and bring them back. Now, if they ask you for an hourly rate, you already have the answer. All you need to do, if this is over 24 hours, you just divide it over 24. So ml over 24 hours. And this should give you 104 ml per hour. That means every hour, this patient should be getting over 100, close to 105 ml. And this is how we can resuscitate it. So you can see the reason why the patient is getting sick is not getting enough fluid or is in renal failure. But we have to calculate how much fluid we can give them. And these are, so this is a dose, simple dose calculation strategy. So if they ask to calculate maintenance fluid, you take their first 10 kilos, multiply by 100, second 10 kilos, multiply by 50, and whatever they are weighted. If it's 100, then 100 kilos, then you multiply the 20 by 80. But this guy weighs 70. So that's the way to calculate hourly rate and 24-hour rate. So the formula, once again, is if you have to calculate 24, you take 100 ml. This is the volume, 50 ml, then 20 ml. Then you ask yourself, how much the patient weight? 70. For the first 10 kilo of the individual weight, then you take the second 10 kilo. This 10 plus 10 is 20. 20, if you remove it from 50, from 70, you get 50. So 50 kilo here. So multiply this by that, and that. And the total will give you the fluid. So this will give you 250 ml, 2,500 ml over 24 hours. The hourly rate, you just divide over 24 hours and you get it. And that is the way to calculate the hour rate. So this is the maintenance fluid calculation. Now, what fluid is the most appropriate? The fluid is the appropriate for somebody who is hypertensive, whose sodium is low. What do you think we should give them? 0.45% normal saline, 0.9% normal saline, 3% normal saline, and D5W. Think about it. The sodium is low. I have low sodium. And my blood pressure is also low. But my creatinine is 1.8. My BUN 32. If you have to choose a fluid, which fluid will you give to this patient? I have normal saline. Remember, patient is hypotensive. Patient is hypotensive, and patient blood pressure is low. At the same time, they tachycardic. Therefore, we need to resuscitate this patient. You cannot give them half normal. Half normal will probably worsen the normal sodium, which is 128. 3% is not going to resuscitate this patient. This is a tricky question. If you don't look at the case, you're going to pay 3%. Patient fine, his sodium is low, but at the same time, look at the creatinine, 1.8 and BUN. That means the kidney is in trouble. Your blood pressure is also low. That means the kidney is not working. Your heart is not getting enough fluid. So, and you tachycardic. These tell you patient is in shock. Hypotensive tachycardia tells you patient in shock, has lost some fluid, most likely has lost isotonic fluid. This is how you apply fluid electrolyte in real life situation. This is why this case study is very important to understand them when you can use it to answer questions regarding standalone. This patient probably is in shock, hypotensive, tachycardia with low sodium and creatinine. This is not a situation you have to give them 3%. 3% is non-resuscitative fluid. They're going to get 0.9%. And that's this fluid is going to resuscitate them, and that will stay in the intravascular system to improve their blood pressure. That is the clinical application of this. Now, potassium is 6. How are you going to treat it? What would you do first? Give the patient furosemide, hold potassium-containing medications, prepare for immediate dialysis, or give the patient K-esylate, polystyrene sulfonate, management of hyperkalemia. What do you think you should do first? If you have to choose one thing, prioritization 101, which one you think you can institute that will help this patient whose potassium is 6? What would you do? Do you give them furosemide, hold all potassium-containing medication, prepare for dialysis, or give them K-esylate? If you know the answer, you can put that in the comment. But how do you manage potassium, hyperkalemia, and which one should you prioritize? I want you to listen carefully. Every time, don't cause any more harm to the patient. You may know the answer because you've seen the question like that before, but read the question carefully. I always say the question is the key. If you know the question, go to the question, attack it, and analyze it, right? I said what? Potassium of 6, action to take first, prioritization. You got to master it. I give you furosemide. Well, it's going to work. It's going to lower your potassium. Okay. I hold all potassium thing. That means I'm not causing you to increase your potassium anymore. This is safer. This is the safest thing you can do. Dialysis is going to take some time to get you to dialysis. K-esylate, which is polystyrene sulfonate. This is taken orally. Oral medication, these take a while to work. Furosemide will even work faster than polystyrene sulfate. I know you know that you can use, number one, furosemide to lower your potassium. I know you know that you can use sodium polystyrene sulfate to lower your potassium, but those are not priority. The priority is to hold any more potassium. Don't give this patient any more potassium. Otherwise, your potassium is going to go up. This is what you mean by prioritization. No more harm to the patient. I hold all potassium is somebody whose blood pressure is hypotensive, right? And you have to do something. First thing, don't give them anything that will lower the blood pressure anymore. So hold it. That's your answer. Now, I told you, patient is now hypovolemic. This is the way the case study is. Patient coming in fluid deficit. Now the patient is in shock. I'm taking you through the journey, all the lectures, so that in case you can understand all fluid balance. Now we have a shock patient. Fluid deficit, if you don't treat it, they'll go into shock. What would you see in hypovolemic shock? I know you know it. What do you think is hypovolemic shock? What are the signs of symptoms of hypovolemic shock? I use this case study to give you all kind of fluid electrolyte information. Know this, please know this. When it comes to hypovolemic shock, what do you see? Do you see a warm skin, bradycardia, bounding peripheral pulses, central venous pressure of 15? Do you see a decreased urine output? Do you see a patient who is anxious? Do you see a flushed skin? What do you think? And do you see a capillary refill of 2 seconds? What do you think? If you see a patient who is in hypovolemic shock, what do you think? The definition of shock is your answer. What is shock? Shock is hypoperfusion. That means there's no blood perfusing anywhere. Blood is going to be shunted to places that is very important. That is the definition of shock. Therefore, if I'm in shock, blood is going to go to the most important, my brain. I don't have enough circulating blood or fluid in the system. What do you expect, therefore? Your skin is not going to get warm. There's no way, right? You're going to be what? Tachycardic, like the patient was, hypotensive and tachycardic. So you're not going to be bradycardic. Just because you know bradycardic is Bad, it does not answer the question. A shock patient is supposed to have tachycardia. Your pulse is not going to be bounding. You're going to use the same content. The buzzword is less fluid. There is no way your pulse is going to be bounding if you have less fluid. If your CVP, which is the same thing as you can equate it to jugular vein distension, your fluid is low, it's not going to be 15 because normal is 2 to 8. So it cannot be. Your urine output, of course, is going to decrease, right? You're going to be anxious because you are in shock. Your skin is not going to get flushed. This is the difference between distributive shock. If you need help with shock, I have a video on my YouTube channel, Shock Made Easy. You should watch it. It will give you all the kind of shock, what kind of signs and symptoms. A flushed skin is good for what? Distributive shock, which is the same as warm shock, right? That is a warm skin. So you don't see this. And your capillary refill should be greater than 3 seconds or 2 seconds. It's not going to be 2 seconds. This is adaptant class. Thank you for watching. But these are content you have to master. So the only thing we worry about, we're going to see in this patient, decreased urine output and anxiety. But the skin is not going to get warm. Patient is going to be tachycardic. Peripheral pulses is not going to be bounding. CVP is not going to be that high. The skin is not going to get flushed. And the capillary refill is that. So this is shock in disguise with this case study, trying to give you all the things you need to do. Now, this is following up. After 8 hours, now we know patient is in shock. So we give them fluid, a bunch of fluid. Patient has now developed fluid overloaded. So from shock to now fluid overloaded. What do you think you should see? Like I said, it's a teaching case study to give you all the things you need to know about shock, fluid, electrolyte management, and case study. Will you feel like a crackles in the lung when you listen to the patient? Are you going to see JVD? Are you going to see hypertension? Is the patient going to gain weight? And do you see cold climbing skin? What do you think? Cold climbing skin. What do you think? Crackles in the lung, jugular vein distension, hypertension, weight gain, and cold climbing. Which of these indicates you are fluid overloaded? I've already explained it from the previous answer, so this should give you the way. If you fluid overloaded, crackles in your lung. If you have too much fluid, JVD. Too much fluid, you get hypertension. Too much fluid, you gain weight. Too much fluid, your skin is not going to get cold and clammy. It's unexpected finding. So 1, 2, 3, and 4 are your right answer. So those are the signs and symptoms of fluid overloading. Now, last one. After 8 hours of fluid resuscitation, now we've given the patient fluid, too much fluid now. Look at it. It's getting crackles bilaterally in the leg, fluid overloaded, right? Edema in the ankle, PD edema, fluid overloaded, right? Blood pressure, like we said, is hypertensive, fluid overloaded. Heart rate, 98. Respiratory rate of that, and a saturation of that. So we know this patient has fluid overloaded. Look at the sodium. How can you be fluid overloaded and your sodium is low? Potassium is normal, creatinine is improving, but look at the serum osmolarity. I want you to think about endocrine. Go back to endocrine. Serum osmolarity is now low and the urine sodium is high. Something should tell you. How can you be fluid overloaded and your sodium is still low? What kind of problem is that? So which of the following should the nurse expect? It's a selected apply. Frequent neurocheck, peripheral edema, bed in the lowest position, fluid restriction, and seizure precaution. What do you think? And let me give you the content. You got to analyze everything. This is a case study they've been giving you in the NCLEX. They want you to put pieces together. I call it buzzword. Low sodium, and then osmolarity of your blood is low. So serum osmolarity is low, and your sodium is low. That means something is diluting, right? But you are fluid overloaded. Blood pressure is high. You have crackles in your lung. You have PD edema. Your urine sodium is high, is elevated. Something is going on. What do you think? Patient get a bunch of fluid. These sound like SIDH, but it's not true SIDH because SIDH is different. There's no evidence of SIDH. But if I give you too much fluid, you're going to look like that. So you have what we call hypervolemic hyponatremia, like hypervolume, too much volume leading to what? Hyponatremia. It's the same thing. You manage the patient to treat the sodium. The sodium is being diluted, too much fluid. In the process, treat them like SIDH. What do you think? Low sodium, you worry about seizure precaution, right? So I do frequent neuro check. I'm going to see peripheral edema because they are fluid overloaded. I'll put the bed in the lowest position. This is your fundamentals of seizure prophylaxis. You're trying to prevent seizures. And this is fundamental case study for fluid and electrolyte. So bed should be in the lowest position. The client, what? Is fluid overloaded. Restrict some fluid. And of course, seizure precaution. It's a select or apply. You don't have to pick everything. You pick those you are 100% sure that's the right answer so that you don't lose a point. But this is a question, it's about seizures because you have hyponatremia due to fluid overloading. So you got to institute what? Seizure precaution. And all of this are seizure precaution. It's the fundamentals of fluid management and complication. So I started with you with patient who has fluid deficit. He came in, we tried to resuscitate it. Patient develop what? Shock. We give the patient enough fluid. Patient develop too much. We get too much fluid and develop what? Hyponatremia. And we have to institute seizure precaution. This is fluid and electrolyte management. Thank you very much for watching and good luck in your exams. Adapting class out.